see me. My name is Dr. Tony Burch. I'm a trustee of Age UK London, and I'm chairing this meeting today. I'm a recently retired GP and, as it happens, a volunteer vaccinator for the COVID vaccine locally to where I live. I want to welcome Dr. Andrew Dharman, our speaker, who's a GP in Ealing. And I'm sorry, Andrew, I'm not quite sure whereabouts in Ealing, but I'm in the south of Brent. And Andrew is going to give us a presentation about the COVID vaccine, particularly aimed at Black and minority ethnic groups. And then we have an opportunity for questions and answers. Andrew says that quite a lot of the answers will be in his presentation, but there will always be room for more. And I think the easiest thing to do is, if you have a question, that you post it in the chat. And if you go down to the chat button at the bottom of your screen, it will, if you click on it, it opens up a panel on the right-hand side. And down at the bottom, it says "to everyone," and you want to keep it to everyone and type your question there. I will repeat that again when Andrew's finished his presentation. But before that, I also ought to welcome two very important people, Kathleen Egan and Sharon Tynan, who are both on the staff of Age UK London, who have run our Get Your Flu Jab campaign, which has now moved seamlessly into Get Your COVID Jab campaign. And so my particular thanks to Kathleen and Sharon for all the hard work they've been doing behind the scenes over some months. And again, my thanks to Andrew for agreeing to be our guest speaker and presenter here. Andrew.
Thanks, Tony. Thank you, Sharon, Kathleen as well from Age UK for giving me this opportunity today. I just wanted to start off by, so I myself am a GP in Ealing, central Ealing area, pretty much practicing every other day at the moment because it's so busy. And if you, I think Tony's touched on a lot of the opening points, which is, if you have any questions, please feel free to ask me in the chat. I've had the pleasure of working with Tony in the, hello? Sorry, I thought there was a question. I've had the pleasure of working with Tony in the North West London RCGP faculty over the last sort of 10, almost 15 years. So, and I've just handed over the chairmanship to two of my colleagues there. And today I'm speaking not necessarily as an expert on the subject, but more of a GP who would like to try and present some of the information, answer some of these queries, talk to you a bit about some of the information I've been able to collect and then present them to you. I've looked at the questions already that were posted, so thank you very much for submitting those. And I'm very happy to try and cover as many of those questions as I can. There will be a few question marks, even after I've spoken, so apologies if I don't answer all the questions, but I'll do my best to try and address them. And certainly anything we can't answer, I think there's no harm in us trying to go away and find out the information and come back to you. So if you're, and the other question is really, if there's anything that you feel that this is something that's either not necessarily relevant or this is something that you want to know more about, then please feel free to make a comment in the chat, and we'll try and make a note of that. And Tony has kindly agreed to keep track of that for me. So I think we'll start off by trying the screen share. Okay. So can you see the slides, everyone? Okay, I see a couple of thumbs up and nods. Okay, so I'll try and recap briefly where we're up to before we go on to the subject of vaccinations, because I think the context is a little bit, it is obviously very important. I'll try not to teach you how to suck eggs, but I think it is important. So we're talking about this novel virus that emerged from the city of Wuhan in China in December 2019. The important symptoms that we're looking out for are the high temperature, continuous dry cough, loss or change to sense of smell and taste. Most people will have a mild form of the disease, but unfortunately there is plenty of evidence that suggests that older people and people of Black, Asian and minority ethnic groups are also at higher risk of both contracting the infection and suffering mortality and increased morbidity because of the infection. Now, this timeline, we don't have to go through this entire timeline, but it gives you an idea of exactly what's happened up to now. And if you look, the timeline sort of ends in March last year with the government's recommendations. But you can see where in 31st of December 2019, when this all started. Now, this image I thought was quite nice because it gives us, you can actually see what we're talking about. And when we talk about the vaccines and the immunology, then we'll understand what we mean by spike proteins. So this is a picture of this novel coronavirus with the little red triangles. Can you see my mouse moving? Yeah. So the little triangles are effectively the spike proteins that you'll hear. So there are lots of spike proteins on the coronavirus, which looks like a crown, like the solar corona, hence the name. And you see the RNA part of the virus internally. Now, viruses can't replicate themselves. They need a host. They need something or a cell to be able to replicate. And so this is one of the reasons why viruses don't do much harm, outside on the table surfaces. But as soon as you touch something, put it inside your respiratory mucosa, like your nose or your mouth, then it can spread inside and cause infection. Examples of viruses that can be prevented by vaccinations include measles, mumps, rubella, influenza, Hep A, and Hep B. And the influenza vaccine, as you know, is constantly evolving and constantly changing, which is why we need an annual vaccination program. And the studies of the strains are based on the year before. If we look at this slide here, you can see here the important part here for us really is this susceptible host part in terms of transmission, elderly, we're immunosuppressed. So this is going to be the focus of what we're talking about. We've talked about some of the main symptoms and some of the other symptoms there. Now, with any infection, this is the kind of pyramid of infection. So the majority of people, 80% of people, will have asymptomatic to mild, moderate symptoms. Asymptomatic, i.e. you don't know that you have the infection. Now, we're hearing on the radio adverts these days that, up to 30% of people may be having asymptomatic infection. So this is very, very relevant and very important because there are people who are obviously, moving around in society who will have the infection and not necessarily know that, not be displaying any symptoms. And this is why the infection is spreading. One of the reasons why the infection is spreading. Okay, so a little bit about the coronavirus, because a lot of people, there are some common misconceptions about the actual coronavirus family. So maybe if we go back a slide. It's a large virus family. It can cause infections in both animals and humans, and it can vary from the common cold to severe acute respiratory syndrome, SARS, which was in 2003, Middle East respiratory syndrome, MERS in 2012. The virus is the SARS-CoV-2 virus that can cause the COVID-19 infection. So that's kind of the terminology that we need to talk about. And it was known, and it's been officially termed by the WHO as a pandemic, pan meaning all, demos meaning people. So it affects multiple countries in a large number of people. So we've talked a little bit about the shape of the virus. We've talked a little bit about how it survives. Now, the important part is this person-to-person spread, which is by small respiratory droplets. You can sneeze it, you can cough it, and it can also be transmitted when you're speaking. And it's caught by breathing in, and two, by touching something and then touching your mouth or touching your nose. The incubation period is approximately 3 to 6 days, but it can vary from 1 to 11 days. And unfortunately, the death rate at the moment is about 0.9%, but it can increase to 11.6% in those over 75 years of age. So it is very, very important in the over 75. And we'll come on to that a bit more in a moment. 5% will go on to critical, 15% will be severe. So that gives you a rough idea of the numbers. And for some reason in children, it doesn't seem to affect them so much. And actually studies have shown that roughly half have got some kind of underlying illness, some kind of serious underlying illness. So moving on to the statistics. Now these statistics are available on the reference at the top of this slide, which you can Google. And it's really helpful because it's got, all this information you can see here on this slide: daily update, testing, cases, and vaccination as well. And you can see here, this is the total number of vaccinations last updated yesterday at 4 p.m. This slide shows the daily vaccination rate. So you can see how many people are getting vaccinations every day. 9 represents the 7-day average. This is the cumulative dose. So you can see how many people have received vaccinations in total. I haven't actually I can't really check the chat, but I assume, Tony, is there anything up to now? Any comments or any questions?
Yes, why don't we take them at the end? Why don't you do your presentation? We'll take them at the end. There are a couple, yes. But
if there's anything, just wave at me and I can see that, Tony.
Yes, I mean, the question that everyone's got is, why are people from BME more likely to die from the virus? And I think that's probably the question on everyone's mind.
Yeah, I think I have an answer for that, but we'll come on to that. So the other thing that I wanted to just touch on is this long COVID, just as a little bit of a recap, which is where people are suffering symptoms of COVID: lethargy, headaches, muscle aches, much longer. So it's something just to be aware of and be sympathetic about. It tends to, 1 in 5 people tested positive for COVID are actually having symptoms longer than 5 weeks. Okay, now the majority of the population are non-immune, which means that we need to deliver a safe and effective vaccination program. The way that vaccines work, a little bit of basic immunology, is that it tries to generate your own immune response to an infection. Okay, and so it's trying to replicate a more natural immune response. And so in the event of exposure, the body is ready to fight, reducing the severity of the infection. But it doesn't stop you from potentially getting the infection. So this is important, and we'll come on to that in a moment. Now, on this slide, we're talking about look at the death rates. You can see, last year, and then if you can see the number of deaths, and thankfully there's been a sharp decline, which we think is lockdown and vaccination related. So it's quite a scary graph, to be honest. But anyway, moving on. So here are some of the other statistics that you can see on that website. Number of people testing positive in the last 7 days, and you can see the graphs, and you can have a look at it yourself. So I would encourage everyone, wherever possible, to have a look at that, because there's a lot of misinformation going around, a lot of WhatsApp groups and all sorts. I know that my parents are equally guilty of receiving things and forwarding them on to me. So this is national statistics. And another common misconception or questions about COVID deaths. People are saying, oh, well, they're just adding COVID-19 to all the death certificates. And that's not entirely true. The way that it's worked out is different in different parts of the UK. But in England, it's if you were diagnosed or tested positive in the 28 days prior, and it also is one of the main causes of death on your death certificate. So there is quite a robust system there. We're going to come on to a little bit more about who are the people responsible for vaccines, because actually I think understanding this process helps you to feel more confident in the vaccine program and how much effort and work has gone into it. So you can see all the different regulatory bodies who are involved. And the basis of any vaccination is 2 things. One is the suitability of the vaccine, that it's safe and effective. And the second important factor is the need for a vaccination program. So a task force was set up in April 2020 to accelerate this process, to facilitate, support any kind of vaccination program. And then the independent regulatory body is the MHRA, which has to give the final go-ahead with any kind of vaccination or medication. At this point, I thought it's really useful to give you a little analogy that I heard from Professor Openshaw, who's an infection control consultant at St. Mary's, on an update that we had for GPs. And the way to think about this is, imagine you're in traffic trying to get through London, the city of London. And if the city is chock-a-block with traffic and there's accidents and all sorts going on, then it's going to take you a long time to get from one side of the city to the other side of the city. Now, Professor Openshaw gave a really nice analogy, which is, imagine you were in a Lamborghini and you didn't have to watch the speed limit and all the roads were clear and all the traffic lights were green and you had an armored police escort getting you from one side to the other side. And that is basically what's happened with the vaccination program. It's been accelerated by taking away some of the really bureaucratic, slower steps and putting as much money, basically they've thrown as much money as they possibly could to support the vaccination program. And that analogy, for me kind of makes sense because, you can understand some of the limitations and how they can maintain the safety, but increase the speed. And as part of the COVID-19 vaccination program, as with any vaccination program, there are three stages: stage 1, stage 2, and stage 3. And stage 3 includes many hundreds of thousands of people in the trials. And they look at the effectiveness by looking at the antibody levels, looking at different age groups. And then phase 4 of any vaccination is the ongoing analysis once the vaccination has been rolled out. Now, focusing on, if we look at, before we come on to the specific vaccines, I just wanted to touch on the initial at-risk groups. So you can see the order of priority groups that you may have seen yourselves on the internet or in the news. And this is also on the government webpage. And you can see the order of priority. The vaccination is normally administered into the deltoid, just there. And you normally will get a vaccination card or a record. There's also a vaccination leaflet that I wanted to share there with you. Okay, so the big question is about these individual vaccines. Now, yeah, we're going to come on to the details of the vaccines in a moment, but I wanted to just go through a little bit about what you'd expect when you have the vaccination. So the Pfizer vaccination is an mRNA vaccination. The way that there's no whole part of the coronavirus, it's not a live vaccine. And the way that it works is the mRNA goes into the cell and advises the cell to produce these little spike proteins, which are then expressed on the outside of your body's cell. And do you remember the little spike proteins from the picture earlier? And so then the body's immune system recognizes those little spike parts and then prepares itself for the future. And the good news is the mRNA part of the vaccination degrades after a few days. The second one, which is the AstraZeneca vaccine, is a bit more traditional. It's called a viral vector. It's based upon something called the adenovirus, which is a common respiratory virus, but it's modified so that it doesn't cause you any illness. And what happens is that the body cells produce these little spike proteins again. So it's all about the recognition of these spike proteins so that your immune system will then prepare itself and then be able to fight off the coronavirus, the actual coronavirus that we're worried about that causes the COVID-19 infection. So it's talking about the recognizable part. And we talked about these the priority groups. And in the priority groups, there is an increased rate in care homes, residential care homes, nursing homes, and older persons are also obviously very much high risk. The immunization both gives you direct protection by preparing your immune system, but also by giving you protection from those around you. It's also, there's no evidence, so coming back to that question that you asked me about the by the BAME group, there's no evidence to suggest that ethnicity is a risk factor. However, certain health conditions are overrepresented in those groups. And the thinking and the theory is that that's the reason why those groups are more at risk. For example, you know, your occupation may be relevant, your household size may be relevant, deprivation can be a factor, as well as access to healthcare can all, you know, limits to access to healthcare can all increase your susceptibility. But it is shown, there is evidence to confirm that there are higher rates of infection. The rates of more serious disease are increased, and the rates of morbidity and mortality, i.e. the symptoms that you get, the illness that you get with the disease, and the risk of death is also higher in those groups. When you go for the vaccine, it's being rolled out at the moment in the priority orders that we've looked at. Currently, I think we as a practice are looking, informing groups in the higher risk between 60 to 65. So this is how it's working. We as practices get told which groups to send messages out to, and then patients get to book through an online AccuBook system to book with your local vaccination center. For the actual vaccine itself, you need to obviously give consent, and part of that is to understand the information, be able to make that decision, and also have capacity. And in those cases where there isn't capacity, then best interest decisions can be made, provided there is discussion with family, friends, and if there is a lasting power of attorney for healthcare. So common side effects with any vaccination, which is the same for any of these vaccinations, is mild redness, mild swelling, local effects. Then the other group of effects includes sort of more systemic effects, you know, things that can affect your whole body, which includes possible fever, muscle aches, headache. Again, these are side effects of the vaccine, and you can't actually get the infection from the vaccines because there's no live or whole component in any of these vaccines. And the third and the most serious one is severe allergic reactions, which is anaphylaxis, which is when you can have very severe effects on your breathing, causing swelling to parts of your body. And with the main vaccine types, you've got the Pfizer vaccine, which is the one that was initially rolled out. I have a date here written, 1 second. I think it was early part of December last year that it got the MHRA approval, and the AstraZeneca, I think end of December, 30th of December was the MHRA approval for vaccination. So the Pfizer vaccination was trialed in 44,000 participants across 6 countries. 1 dose was given alongside a placebo, and they were looking to see how the body would respond. There was spike proteins detected after 21 days, and after a second dose, those numbers increased, and it was thought to be 95% effective after 2 doses, and over 65, 94%. The AstraZeneca was started the trials in April 2020, and involved 24,000 participants in the UK, Brazil, and South Africa. And there was approximately 70.4% efficacy. The big difference between the two in terms of the practicality is the cold chain storage, which is more relevant for us and the people organizing the delivery. But the Pfizer vaccine needs to be stored at a much colder temperature, -80 to -60, and then you have a window of opportunity of 6 hours stored between 2 and 25 degrees in a cold bag for delivery. So In general, the AstraZeneca one is the one that goes out to the care homes because it doesn't need to be stored at such cold temperatures. It can be stored between 2 and 8 degrees like any other vaccination. So those are a little bit about the actual Pfizer. Now, the questions about boosters and annual jabs and what happens to the efficacy, there are big question marks. So it's not fully understood whether we will need annual vaccination programs, much like we need with the flu vaccination. We also are unaware of the effects at this stage of whether you need a further booster dose. Obviously, the efficacy and the safety looks at the effect of protecting the person, but we are not sure if the effect of spread is reduced because of immunization. So one thing we talked about was, I mentioned was, you can still get coronavirus infection, but the immunization is to prompt your immune system to fight it. So in theory, if you have the illness less severe or for a less length, a shorter length of time, then in theory, potentially you can spread it less as well. But again, that's not known. The other questions were around flu and COVID. So the answer to that is, in an ideal scenario, in an ideal world, there is a 7-day gap between these immunizations. But the current guidance from NHS England is that wherever it's important to get the immunity into the person, for example, in a care home, and it might be difficult to get the vaccines to that patient, it is safe to give both of them at the same time. Both of them are not live vaccines, so they are parts of the vaccines that your body recognizes. The other important difference between, sorry for jumping around a little bit, I've got one note here that I forgot to mention, which is the Pfizer vaccination. You do need to be observed for 15 minutes after the vaccine. And the AstraZeneca one, which is the one that is being given at the moment in the majority of centers, doesn't need a 15-minute observation period. So if you are told, oh, you can go home immediately, and don't panic, basically, because with the AstraZeneca one, you don't need the observation period. So I think so that's these are some of the other excipients inside the Pfizer vaccine. So you can see some of the other elements. So if you're allergic, if you have an allergic or anaphylactic reaction to a Pfizer vaccine, then obviously you're not allowed to have that again. And also if you're any of these chemical compounds. Now, the risk of any of these compounds giving you a chemical reaction or an allergic reaction is low. However, people do ask me what else is in them, and this is what else is in them. It's the same things that are in every single vaccine, and it's to help with storage and carriage. This is a picture of the Pfizer vial, so it gives you an idea, and you can see the once it's been reconstituted or made up, then you've got 6 hours storage at 2 to 25 degrees. And this is a picture of the AstraZeneca box and vial. And these are the contents there. And that's it from me.
Thank you very much, Andrew. I know that there's a Q&A session later, but there are some questions that have popped up in the chat, and I wonder if we can quickly take them. Those of you who've asked the questions, some of the answers have been covered, but if I can read them out, and they separate into 2 lots. The first one is about the vaccine, and if I can just read out the questions, Andrew. Why 2 doses? Why 3 months apart? And are they different doses between the first and the second? How soon after your jab are you immune? And does the vaccine contain live COVID-19 virus?
Okay, so that one's an easy one. That there's no live coronavirus in any of the vaccines. So the way that the 2 work, and also the same with the Moderna, which is a newer one coming out, that's also works the same way, which is it makes the body's cells produce this spike protein, so that and so the body can recognize the spike protein part of the vaccine. So you're not getting actual vaccine, live vaccine or whole vaccine injected into you. So you can't get the infection from the vaccine.
So it's really important to stress that the spike protein is the bit that makes the thing infectious in the first place, that attaches to the cell, but it doesn't include any of the genetic material.
Thank you. Yeah.
Yeah.
There was a question about doses. So again, I'm not an expert on the literature behind the dosing, but the dosing is looked at in terms of the trial data. There is evidence that from the first Pfizer, you do get a spike protein response after 21 days. So you probably will, like with any other vaccine, basically, you will get a response usually, 4 weeks, 4 to 6 weeks, but you may be developing some immunity sooner. In terms of the dosing, I don't know the exact answer to the data with regards to the current gap and longer gaps, and I think that is being looked at the moment. But I think the theory is that getting one jab into more people is more important at the moment. And there was a question about immunity, Tony. I can't remember what that.
Yes. How soon after your jab are you immune?
Okay, so that gives you a rough idea of when you're immune. Obviously, it's not an exact science.
Right. Why are we not getting, this is related, why are we not getting the second Pfizer vaccine dose within 3 to 4 weeks as originally recommended, especially at the more at-risk groups? Now, you have just answered that it was meant, that it was a difficult call, but they wanted to give the first dose to as many people as quickly as possible. And am I right in thinking that they're carefully watching immune levels in the meantime?
Absolutely, yeah.
Yes.
But I think it's obviously it's being very closely monitored at the moment. So I think if anyone gives you a comment about that at the moment without the data, then I think it's probably opinion rather than statistics.
Yes. If you can get and pass on the COVID after the jab, what is the difference between having it and not? If you can still get and pass on the virus after the jab, what is the difference between having it and not?
Well, the main thing is the protection of the person against the severe complications of COVID, which includes the acute, short-term risks of serious illness, lung disease, and obviously death. But also, in theory, it should reduce your risks of therefore long COVID as well.
Right.
And
now this is
there was another part to that question. It was a transmission. So the thing that's about the transmission is the theory that you still, just because you've had the COVID vaccine, it's more to do with the fact that you shouldn't therefore say, I've had the COVID vaccine, therefore I can go out shopping and do whatever I like. It's you should still act in line with government recommendations. Right.
Sorry, there's a couple of technical ones here. Does taking a course of steroids affect the vaccine from working?
So I know that a course of steroids is used in part of the treatment in a more kind of severe form where your lungs are not working very well. Getting a course of oral steroids currently is part of the treatment. So if you're, I think it's a very specific question, and I think if you are on, say, for example, a low dose of steroid, there is a certain level of steroid where they say that it does have impact on your immunity. So I think it's always better to, if you're asking as a patient, I'd say it's always better to check with your own GP. But if it's a question about general principles, the steroids are used in treatment, but at a certain level of steroid, it can affect your immune system.
Right. Now, I mentioned this before. Why are people from Black and minority ethnic groups more likely to die? Why are people from Bangladesh and Pakistan reluctant to get vaccinated? Why do some young people, I will repeat these, Andrew, it's just to give you the flavor. Why do some young people in their 20s to 40s with no health conditions get to have the vaccine now? And is it true I can just walk in and call and get scheduled? Some people who had done this and were vaccinated.
So the answer to the Black, Asian, and minority groups, I think, according to the evidence, well, first of all, there's a brilliant paper on the government page, a 69-page long paper about exactly this and the government's recommendations. So they are looking at this and taking it very, very seriously. But there is evidence that there's no link to ethnicity. So ethnicity itself is not an increased risk factor, but it's to do with the fact that, you know, there is a higher risk of heart disease, diabetes, and other conditions that could potentially affect your immune system in those population groups. So the theory is that higher risk of those diseases, therefore, you know, your potential for getting the infection and getting more serious complications of the infection are higher in those particular groups. To answer the question about reluctance, I think it is. A lot of it is misconception and public opinion. There is a lot of social media, like we've touched upon social media, there's a lot of social media messaging going around, not necessarily from the most reputable or data-rich sources. So I did actually, I whizzed through it, but I did actually write a little bit about being careful about what you're reading and what you're sharing on. Almost every other thing that gets shared to me by a family member, I normally reply with the evidence why that's wrong. So maybe 1 in 20 is reputable. So, you know, and I think we have a real responsibility as you know, intelligent people to spread, you know, correct information and try and stop or halt the spread or challenge the spread of less good information, let's say. And in terms of, I mean, reluctancy, there's other aspects to it, and we touched upon that. There could be a language element, there's a deprivation element, ability to access healthcare. Quite often you may turn to your own population groups for support and advice. So this is where the leaders in those groups do have a responsibility. And I'm Sri Lankan. So in terms of my heritage, and I've been asked to do a talk to a community group for this reason, and I've agreed to do the same sort of talk there, because I think it's important to hear it from someone. I mean, I shouldn't really be saying this as a sale, but I myself had COVID in March last year, unfortunately, but touch wood, I wasn't too seriously ill. I was antibody positive at the time, so my wife and I got it at the same time. So it was a bit of a nightmare with the kids because we couldn't get any access to childcare. And then I had the Pfizer vaccine, 1 dose, about a month and a half ago, which I was you know, running for. Because at the end of the day, you know, the risk of getting this infection and getting it at a young age is there. And again, we've suffered a lot of, you know, loss, sadly, in our practice with patients, and it's really heartbreaking. A lot of older people, but we've had a couple of really young people as well who are fit and well. So, you know, and one of my closest friends was very sick, and you know, nursing staff we know have been very sick. So it's very serious. And the advice from Professor Openshaw when he was asked this question by a GP, which was, which vaccine would you have? His answer was, whichever one my GP said was available at that time. So, you know, that's a professor of immunology and infection control. So I think that says it all, really. And I was the same. I said, you know, I'm patient facing. I see patients in the surgery. We have a lot of people coming in for immunizations, for smears. So it's important to protect myself and my staff. I hope that answers that question.
Thank you. There's a question about scheduling. Is it true I can just walk in or call and get scheduled? Some people have done this. And I think I can answer this, is that it's a risky business, because if they've got some spare at the time, they might slot you in, but otherwise they might turn you away. And it's much better to get scheduled and wait for your call. And if you haven't been called and you're in a certain age group or risk group, then you need to contact your practice, isn't it, Andrew?
Yes, so Tony is absolutely right. I think these were when you might get a few left over at the end where people haven't turned up for their appointments and they've been lucky. I certainly wouldn't do that because you know there's this very small numbers basically of those, and actually everyone is getting these AccuBook invites coming through now. So I would expect everyone to be hearing, you know, between certainly over the age of 60 in the next 2 to 4 weeks. So what was the other part of that question, Tony? There was something right at the end you mentioned.
No, that's it. But I've got
oh no, accessing. So yeah, so if you GPs are able to include certain individuals as high risk people, but it's a case by case basis, and you do need to discuss the case with your GP. So and at the moment everyone's pretty inundated, so getting through may be a challenge. But one other option that a lot of practices have, well, all practices should have now, is e-consultation. So you can write the question through your practice website, and you look for e-consultation on your practice website, and you fill in the question, and it will ask you a few further questions, and that way you'll get an answer within the next few days. That may be the sensible way of doing it without inundating or giving calling too many people calling in. And there are some people that I've given these extra invitations to. For example, someone who is the only carer for her elderly mother, and she's the one who has to go out and do the shopping and everything. So and the mother is housebound. So in that case, I think there is a risk to the mother.
Thank you. The AZ vaccine has ethanol in it. Could this be a problem for some BAME people?
It's a very good question. I don't know the answer to that question, if I'm honest. Sorry, that's something we might have to look up. Okay, leave that with that and with me, and then maybe we can. I'll feed back to
okay.
Aaron.
Another GP is scheduling the second doses, and I think the answer to that is we don't know, isn't it?
No, I'm in the same boat, to be honest. So we just wait to be contacted, and that's it really. I was told 12 weeks from the date of my vaccination.
Would it be safe to go out of my home, as I have not been out of my home since March 2020? Well, I'm sure there's a lot of people wanting to ask that question.
Yeah, I think so. All of these sort of questions are really clearly answered on the .gov website, which is important that we're all aware of and checking, because it's a really good source of accurate information. Your practice websites will also have a lot of this information as well. And it's very difficult because obviously in those people who are in the extremely vulnerable group, you have to be very careful. And those are the very, very high risk people who may be undergoing chemotherapy for cancer at the moment. There is a list of the extremely vulnerable group. And so you have to be very cautious, and the advice is in black and white. And I would check if anyone asked me that question. I would check that person's history. I would check their medication list. I would check what they're on. But I mean, if you're not in the extremely vulnerable group, then going out for some fresh air and going for walks, being socially distant, I think is acceptable.
Thank you. And the last one is a good news story. My wife and I had our AstraZeneca vaccine on the 26th of January, and there is no adverse effect so far. Well, if you don't have an adverse effect within the first 24 hours, you're not going to get one. So well done for escaping it. Some of my friends have had quite severe systemic things, terrible tiredness mainly, but other people are having nothing at all.
Yeah, I mean, common side effects include the local effects of a sore arm, which is what you may experience with a flu jab, for example. And quite often people will get, some people get a systemic, side effect, which is quite a much lower number. And those systemic side effects, including mild temperature or body aches, and you feel like you've got the illness, or you feel like you've got flu, or you feel like you've got coronavirus, but actually that's just your immune system working. And that happened to me because I had coronavirus, COVID, in March. And so when I had the Pfizer vaccination, my immune system was ready to work quite quickly and quite hard. And I did get a bit of tiredness and some muscle aches. So, you know, and I just took some paracetamol, drank some water and slept early, and I was fine after a couple of days. Kathleen's got her hand up, I think.
Yeah, it was just two observations at Age UK London. We've had quite a few people contact us from various communities who've offered case studies to say they've had the vaccine and they haven't had serious side effects, and they're very positive about it. But it was just to add that we have access to a lot of information in community languages. And when we send out the slides and the report of today, we can add links to those. So if people want to spread information answering some of these types of questions in different community languages, they can just click on that and get that. So we'll send that out.
Thank you very much, Kathleen. I just had to say, somebody has pointed out, not all older people have a PC. That is, I know we've been talked endlessly about digital access and inclusion for all sorts of groups, particularly for older people. And that's not an issue that we can crack on a call like this, but we're very well aware of it. And Age UK London is one of many groups, including lots of local Age UKs, campaigning for better digital access for older people.
But if I may just add to that, I think as a general point, and I keep telling everyone this, friends, family, patients, is that community and looking after each other is so important at the moment, because people are struggling so much with isolation and mental health problems. Just reaching out, even on the phone, how are you, what's happening, do you need anything, do you need any help, is so important. And I think you know, as a general comment, if we can do that better as a community, looking after even just the people on our road, then we create a network.
And this is what's happening, Andrew. I'm just going to say I'm involved in my local mutual aid group, and it is fostering communities as people are looking out for their neighbours, and all sorts of other things are coming from it. And I'm hoping that this can be one of the side effects of the pandemic, that there is an increased sense of a need for community and that people can become more community minded. I will stop there because there's
one hand up.
Oh, sorry,
yeah.
Sharon.
Oh, Mo Draper, I think.
Yeah, sorry. My chat button hasn't got a send button on it. So there's an important question that I'm being asked as a support worker. If somebody's on antibiotics and they've had the vaccine, you know, antibiotics are usually designed to attack foreign bodies. Would that be affecting the virus, the vaccine sort of dead virus that they're putting into people? If they were having a long course of antibiotics, would that interfere with the vaccine in some way?
So I think the answer is no, because antibiotics tend to be they tend to target bacteria. So it shouldn't affect. You know, there are a couple of ways that antibiotics work, but it shouldn't affect anything to do with the vaccine.
Right, and just one more. What are the risks of not having the second dose within the time scale that's been advised by the makers of the vaccine? What's the risks of not having it in time?
Yeah, very good question, and it's a difficult one to answer accurately, to be honest. But one of the things that I wanted to show you with the pictures of the virus and how the vaccine works and the spike protein is to get a kind of a basic understanding of immunology, which is the fact that the way the vaccines work is to try and put these little things on your cells just for a short time, so that your body recognizes those parts and generates an immune system. And you know, it varies from person to person how much response you get, but you do get a response. So the more vaccines you have, or the more boosters you have, the more response you get. So obviously that needs to be married up with obviously the cost of doing the vaccines and rolling out the program. But actually, you know, if they can say that, you know, 95% after 2 vaccines is pretty effective. But if you said, you know, I don't know the data for just one vaccine. I'm not sure if the data is available, but, you know, if you said, oh, you've got 70% or 80% efficacy with one, then, you know, if you said, oh, you've got 70% or 80% efficacy with one, then, you know, if you said, oh, you've got 70% or 80% efficacy with one, then, you know, if you said, oh, you've got 70% or 80% efficacy with one, then, you know, if you said, oh, you've got 70% or 80% efficacy with one, then, you know, if you said, oh, you've got 70% or 80% efficacy with one, then, you know, if you said, oh, you've got 70% or 80% efficacy with one, then, you know, if you said, oh, you've got 70% or 80% efficacy with one, then, you know, if you said, oh, you've got 70% or 80% efficacy with one, then, you know, if you said, oh, you've got 70% or 80% efficacy with one, then, you know, if you said, oh, you've got 70% or 80% efficacy with one, then, you know, if you said, oh, you've got 70% or 80% efficacy with one, then, you know, if you said, oh, you've got 70 then it's it's still good protection.
There's also something about how long your immunity lasts for, isn't there, Andrew? Is that the booster second dose is meant to prolong the amount of time that you have a decent immunity for? Because I mean, we all know about our memory cells and what's happening to them at our age, but at least I do. But your immune system has memory cells as well, and the second booster dose is about as much about stimulating the immune system's memory.
Yes, yeah, and keeping that immune system up for longer. So this is where the questions about annual program isn't understood yet, but it may be the case that if the immune response isn't maintained, then you may see some kind of an annual immunization program, a bit like what we have at the moment with the flu vaccination program.
Okay, thank you so much, Andrew, and thank you for all those people
Tony,
who've put questions in the chat.
Tony,
yes.
Hi, I've had my hands up.
Oh, I'm sorry.
Yeah, it's TJ.
TJ, I'm sorry, you're on the edge of my screen and I actually haven't seen your hand because there's a half thing getting in the way, and I do apologize. Far
That's
away.
okay. Thank you. I'm Tracy from Lucian Pensions Forum. Doctor, thank you, Dr. Andrew, for your presentation. Very informative, very informative. In terms of one of the questions that were asked, why are BAME, and I hate the term, but the mortality rate is higher. I would say one of the contributing factors was early on when the virus did start to spread, March, April, lots of people were told in the Black community, in the African Caribbean community and Asian community, that we wouldn't contract the virus because of our genealogy, our melanin, was less likely to get it. I saw that as false information because a virus is a virus and the virus don't know any race. You know, it's a virus and how it operates. So I'm not medically minded, but I personally felt that was put out in the media so that people wouldn't focus on the fact that they didn't have appropriate PPE equipment. Because remember, we didn't have much in our hospitals at that time. And I read that report that you mentioned about the overrepresentation of African Caribbean, Asians in terms of the death rate and contracting the virus. And it made interesting reading. I would say a lot of the rationale behind that was because of the type of jobs that they're doing, you know, frontline staff and so forth. However, let me just quickly go on to the question that I want to ask you. You mentioned that the virus doesn't actually stop you from getting, the vaccine doesn't actually stop you from getting the virus. What it does, it increases your immune system. Is that correct?
Yes.
Right, okay.
That's the same with
if that's the case, yeah. So what it's supposed to do is lower your risk. You also said that when you have the vaccine, it doesn't mean that you couldn't transfer the virus to somebody else. Is that correct?
Yes, it does, yeah.
Okay. So what's the purpose of people having the vaccine? Now, please don't anyone think that I'm an anti-vaccines. I'm not. What I am very clear about is that what I see emerging from our media is this talk about these anti-vaccines, these conspiracy theories. I was quite taken by Panorama, who did a documentary on a webinar that was held on the internet, talking about all of those that are against the vaccine, and some of them end up having to have it. So I don't really want us to get too caught up in that, because as far as I understand it, it's not mandatory, and people do have a right to make a decision what goes in their body. I respectfully recognize that, like you said, you're not an expert. This is something that you said at the top of your discussion, and that you are a doctor who wants to help people to understand the process of the vaccine. So the question that I'm asking is then, if the vaccine is to help you to increase your immunity, are there not other ways that people can increase their immunity? And if there is, why is that not being shared as well? And another question I want to ask you, are people looked less or frowned upon if they make the decision not to have the vaccine? Because,
okay, so
yeah.
Okay, I'm sorry, I'm going to have to ask you to hurry up this. I've just seen the time, it's 3 o'clock already. I do apologize, but we've got to get to move on.
yeah.
Interesting questions from Tracy, though. I'd be interested to know what she's, some answers.
Yes, oh, they're really good
Yeah,
questions.
Yeah.
Just we have a time problem. Yeah.
Yeah, so I'll try and answer those quickly as best as I can. Yeah, again, I'm not the foremost COVID vaccination expert, but I can try and give you some of my insights. And I think with the media side of things, I don't know, if I'm honest. I don't know what these media reports were, but my aim today, in a strong way, was to show you what resources and what has gone on behind the scenes to show you how much work has gone on into the COVID vaccination program to be quite a powerful reassurance, and the agencies involved, the numbers involved in the studies, and the safety aspect of vaccination, which is absolutely paramount. So I think that's the first thing that I wanted to say, that this is not somebody just going, like you might think, oh, here you go, mate, you have a contract and off you go, which is the kind of, there is a lot of public perception about that, and the way that these process have to be followed in a very strict way, and go through quite a lot of regulation. It's not something that can just happen overnight. In terms of what the media reports at the beginning, I can't really comment. I personally wasn't aware of those media reports, but I certainly think occupation is known as a factor, like I mentioned before. I think frowned is not having the vaccination frowned upon. I'm not sure if that's an answer for me to say, but in terms of what we're talking about here is we're talking about that triangle where 0.9% die, and over 65s 11.9% die, and that's what we're talking about. And we're talking about the critical below. So the majority of us are going to be fine. And part of the pandemic is to protect yourselves from this. So for a lot of people, it's not real. they don't see it, they don't experience it.
Doctor, no disrespect, but you're not answering my question.
Okay, you asked quite a few questions. So which bit would you like?
When you spoke about the immunity that the vaccine gives you, and the fact that if you have the vaccine, it doesn't stop you from transferring the virus to other people. And if the vaccine is given to people to increase their immunity, then what is the point then? And if that is the point of the vaccine, then why aren't people being told about other ways they can increase their immunity?
Okay, so that's quite a complex question. And the answer to it is, one, they're looking at the reduction of transmission rates right now. So there's no evidence to say that is reduced at the moment. But the theory is that it is, and we're hoping for the data to come out to show that it is, so that you can see that transmission is reduced. But what I said in my talk was that by the way that the immune system responds to the infection, potentially you have the infection for less length of time, potentially you have it less seriously. So you have the potential is that you have less risk of spreading it. So this is the theory behind it. But I don't have the data now to support it, but it's being
So the theory is a hypothesis, yeah? It's nothing concrete until the research comes in.
Wait a minute, it's very difficult because the data's coming in all the time and everyone's pouncing on it and pouring all over it. Increasingly, as time goes on, we're seeing that since the vaccine started, it's not just the lockdown, but the case rate is falling very rapidly, and particularly amongst older people who've had the vaccine. And so I think we can take something from that. Let me say, I had the privilege of working with somebody, we were doing vaccinating together, who was in charge of all the care homes in Brent, my borough, jointly employed by the local authority and the CCG. And this was 3 weeks ago, and he said, I have seen virtually all the care home residents had their jabs, 3-week gap before they get immune. And he said, I've started to see the infection rate falling. And when people do fall ill with it, they get it much milder. And that was 3 weeks ago. And I think we can follow from that.
That's a good thing then, Tony.
Yes,
what
absolutely.
You're saying is the vaccine, if you take it, doesn't mean you won't get it or you can't transmit it. But it just means
that's the question that we need confirmation from, but it's looking as if it does stop you transmitting it, but you can't be absolutely sure until you've got the scientific evidence for it.
But the
and
doctor
that's
just
taking time.
Well, I think the doctor just said it doesn't. What's good about what you've just said, it minimizes and lessens the severity.
Yeah.
Right. That's what's important, because the doctor said a moment ago something different.
No, I did actually say in the talk also that it does reduce the severity of the illness.
Yeah,
and
I know you did. Yeah.
Yeah, and the mortality and the morbidity. So it does reduce. That's the whole point of the vaccination. The question about transmission risk is what Tony is commenting on now.
Yes.
Which you said it.
And can I just answer your next question?
Well,
I've been following the vitamin D story quite closely. And there's been quite a lot of research done into other methods that purport to boost the immune system against COVID. There is no evidence that anything else does, including, surprisingly, zinc as well, zinc supplements. There is some, but it's not statistically significant evidence that taking vitamin D supplements that may be particularly important with people with a lot of melanin in their skin may boost the immune system, but it's not a very big effect.
Oh, no. It is scientifically proven, Tony. Sorry, I have to disagree with you. It is scientifically proven.
Sharon, you're muted. Sharon, you're muted.
But I understood from Tony that the difference is very, very minimal. That's what Dr. Burch is trying to say.
Yeah, there is an effect, but it's not statistically significant, and so it's difficult to evaluate it. It's not stopping me from taking vitamin D supplements in the winter months, but I'm not taking it because it's going to protect me from COVID. Well, actually, as a vaccinator, I have had the jab, but otherwise I'd be waiting patiently and jumping at the chance when I was offered a date.
But some medical reports, because I'm taking it myself, zinc, vitamin C and vitamin D3.
Yes, it's just that someone who is very interested in this has pointed out that, surprisingly, and he said he was surprised, there's not a lot of, there's really very little evidence that they're affecting COVID. That's all I can say. I'm not going to take them, but keep it in.
They're harmful to take, are they?
No. You don't take too much of them.
Well, I take them every day, so
yeah, just don't take more than the recommended dose.
And also, I take my multivitamins and vitamin D as well every day. But that's standard advice, which is evidence based, because your body
you
will
can take them all,
doctor.
Okay.
Evidence based.
Yes.
Yeah.
Kathleen, you've got your hand up.
Following on from evidence-based, and I understand that people want certainty about things, and there are some elements of the vaccine to do with the latest science on the certainty around transmission that is coming through. But there are some certainties, one of which is we were running a couple of weeks ago at about an equivalent of 50,000. We had 1,800 deaths one day. That's about 50,000 a month. Disproportionately older Londoners were dying, and disproportionately Black and Asian older Londoners are dying. The one certain we will have reduced mortality and reduced severity of illness if we have significant take-up of the vaccine. Now, there are other things we don't have certainty about, and I appreciate that we all want, in a very uncertain time, reassurance. But I do feel quite strongly that the message is that, you know, the ways out of this pandemic are the heroic efforts of the NHS, but they are also large-scale vaccination. I think that evidence is fairly unequivocal.
Thank you very much. We've got 3 minutes before we have to close the meeting. Andrew, have you got a couple of quick last remarks you want to make?
No, just thank you very much for the opportunity. I hope that that was helpful, and thank you all for your questions, and thanks, Tony, for your chairing.
Thanks for your time, Andrew. Thank you.
Thank you.
Andrew, are you happy for me to share your slides?
Yeah, there's some slides that they're obviously copies from the government website. So let me go through them and just make sure they're all shareable.
Thank you.
Thank you. Kathleen, any comments from you?
No, it's a difficult time, and I know we're all seeking certainty, and it's hard. And I think it's good that people are asking the difficult questions and that we're all working together on this. I would just like to say, if there's anything we can do to help promote information and reassurance to communities across London, please let us know and ask us those difficult questions, and we'll try and find out what information we can, the latest information, and we'll get it out to you.
Yes, and I think one of the things that when I said the information's coming in and people are pouring all over it, there's questions like, how long will my immunity last? And we're not going to know until we get there, kind of thing. So it's a very fast-moving, thinking about Andrew's Lamborghini. I don't know about that, but it's certainly a very fast-moving story as we're desperate to get more information all the time.
Yeah, and I think this 3-month wait is worrying people because, you know, they're thinking, well, after 6 weeks, my immunity is going to go back down. I'm not getting that second dose for another 6 weeks.
I can completely understand that anxiety. Sharon.
Well, talking of anecdotes and Lamborghini, there was a very nice, I heard another doctor say an anecdote around when people were concerned about, you know, oh, I should be getting my second dose sooner rather than later. And they said their analogy was that it was better that people had one dose as opposed to getting everybody in ones and two, you know, having their second dose and not doing a whole load of others. And they compared it to driving along in the dark. And wouldn't it be better to have one headlight than no headlights? And they were like going, well, it's better that you got some protection and not necessarily, you know, even though it's worrying for a lot of people that they, you know, the goalposts changed and it was extended. But we know that there's robust you know, all the regulatory bodies that looked at this and have been advising are happy with that. But I like the idea of one headlight rather than no headlights.
Headlights are going to go out after 6 weeks. I'll have no headlights again after 6 weeks.
Yeah,
that's the, you know, that's the war. It just seems a long time from 3 weeks to 3 months. You know, if they
my guess is it'll end up being less than 3 months, but that's just an uneducated guess.
I hope so, Tony.
And also, I'm not sure about the 6 weeks of immunity because, you know, anecdotally, you know, we see antibody levels dropping 6 to 9 months after actual infection. So I'm not sure why the 6 weeks number has come, but I think your immune response lasts a lot longer than 6 weeks once you've had one injection.
Right. I think we have to close the meeting there. Thank you so much, everyone, for your interest, your questions, your contributions. Particular thanks to Dr. Andrew Dharman, our speaker. And
thanks,
we get those slides out to you just as soon as we can. Thanks so much.
Thanks to
Thank you very much,
as well.
Thank you so much.
Thank you.
Thanks, everyone. Thanks everyone for joining in.
Well worth it.
Thank you.